In my talk, I'm going to try and focus on the need for good population-based cohorts to provide the infrastructure for population health, for discovery, and for becoming a bridge between basic sciences and population sciences, between technology and healthcare delivery, if you like. And I'm going to use the example of the CARRS cohort, which is a premier cohort in India based in Delhi and Chennai. So when you look at the history of science, particularly in medicine, cohort studies have played a huge role in terms of unearthing very important patterns of disease and their causes. What cohorts are populations of people with something in common. And the important thing that the ideal cohort would be a cohort that is representative of that particular population. Like the British doctors cohort was all the doctors in Britain. They measured their tobacco habits, those who were smoking, those who were not, and then followed them forwards to see who developed lung cancer, who did not develop lung cancer. That is a classic cohort starting in the 1950s. The Framingham cohort gave the world a lot of information about cardiovascular disease. And what that cohort is the entire city of Framingham in Massachusetts. They were surveyed and then followed up on a regular basis for a long period of time. That study is still ongoing and has given us tremendous knowledge about cardiovascular disease prediction, patterns, risk factors, treatments, etc. And the Pima Indian cohort is a Native American cohort. Again, the entire reservation in Gila River in Arizona, which is the Pima Indian reservation, is surveyed from ages of 5 onwards. And everybody is followed every 2 years. So that cohort has given us a world of information about diabetes and its causes. So when you look at all these population-based cohorts, they all have certain common features. Number one, when they set out, they have huge vision into the future in terms of how to produce a science-driven kind of an approach to developing an infrastructure. They've all tended to be population-based. So you don't want to start with a cohort of hospital patients, for example. You want to start with a population-based cohorts of people who have the disease, don't have the disease, who have risk factors, don't have risk factors. And the younger you start, the better. So that, for example, representative of the various cities or villages. They've adapted measurement and technology over time. And they've tried to connect basic science, clinical medicine, and population science seamlessly. They've also heavily invested in long-term infrastructure. And the final point that I want to mention is these cohorts have tended to be well-resourced. Without that, it's difficult to conduct a 10, 20, 30, 40-year cohort with solid infrastructure. And like Srinath mentioned, India needs good population-based cohort studies because otherwise you're borrowing information on disease, their patterns, on prognosis from other countries, and it may not directly apply to India. You require multidisciplinary collaboration, and this is where you can embed the technologies and basic research very effectively. The CARRS cohort, or the Center for Cardiometabolic Risk Reduction in South Asia, was originally funded by the National Heart, Lung, and Blood Institute in the US. It's a collaboration between the Public Health Foundation of India, the All India Institute of Medical Sciences, New Delhi, the Madras Diabetes Research Foundation in Chennai, and Emory University in Atlanta, and also the Centers for Disease Control in Atlanta. So it's a global collaboration which started about 12 years ago. It's a population-based representative sample of 2 cities, Delhi in North India and Chennai in South India. And the population accumulation has been done in 2 serial samples, CARRS-1 and CARRS-2, which I will describe briefly. And the first sample, which has now been followed up for over 8 years. This is a very carefully characterized geocoded study population. And all the other thing we do is store sera and plasma and urine and DNA. These are stored in a biorepository. So just to show you the schemata, in 2010, 2011, we took a representative sample of Delhi and Chennai, and those that contributed bloods were about 10,000 odd people. And that cohort of 10,000 has been followed up annually with paper and pencil and for deaths and cardiovascular events, diabetes, etc. And every other year with blood examination. So there's a large field team that goes out into the community, to test these people every 2 years. And so this is an ongoing organization that goes on. And CARRS 2, using a similar sampling approach, another cohort in the same cities was constructed in 2015, 2016, and that's about 9,000 people, and they're also being followed up. So you have the benefit of about nearly 20,000 people being followed up longitudinally, and you also have 2 serial time points to see changes in the population over time. So this provides a dual advantage. The follow-up has been tremendous. About 65 to 85% of people come back for every exam, and over 90% of people have had at least one follow-up. And this is very difficult to achieve. Even the best cohorts in the world have not done this. We are measuring at several levels. At the level of the environment, we are measuring using geocoded methods and technology. The built environment, green space, air pollution, etc., are being mapped and measured very carefully. At the level of the individual, because of the amount of budget we have had, all we have done so far is repeated measures of cardiovascular risk factors like cholesterol, blood pressure, glucose, behavioral measures, social factors, etc., through questionnaires. And then everybody is being followed up. And like I said, the follow-up has happened for up to 8 to 9 years now, and it continues. So we have got self-reported cardiovascular disease or hospital-diagnosed cardiovascular disease, self-reported diabetes, and we have also measured glucose to diagnose diabetes. We are ascertaining death, and every time we know of the death, we do what's called a verbal autopsy to get the precise cause of death by talking to the relatives and doing a careful history and also looking at the charts. This is a unique population, one of the best cohorts in South Asia, and we believe this is going to be a gold mine of a resource that needs to be preserved and grown. It provides scientifically informative distribution of various exposures such as weight, the phenotypical presentations of diabetes and cardiovascular disease, has provided data, has clearly shown that the population is at high risk for cardiovascular disease, high prevalence of diabetes, dyslipidemia. We are finding high hepatic fat in the Indian population in spite of relatively low BMI compared to other populations in Europe, in America, and in Latin America. And the results are widely generalizable to urban populations in South Asia, at least. Just to show you, these cohorts are huge organizational challenges, huge level of administration involved. I don't need to go through the list. Huge amount of data coordination and field coordination needed, and the field staff, the quality assurance, the amount of care and resources that is needed for this kind of operation on a regular basis is not easy. And these are not resources that you get by applying for a project grant. So these require infrastructural grants. And then very relevant to all of you is the analytical resources to develop the database management, the biostatistics, the advanced analytics, the informatics. Ultimately, the quality of data collection is very important because what goes in is what comes out. So if what goes in is not high quality, then you really cannot rely on the results. It doesn't matter how sophisticated your analytical methods are or how sophisticated your genomics measures are or your technological prowesses. Unless you have the good, high quality organization and infrastructure in a cohort, it doesn't work well. Just basically, these are the kind of data we get, and I don't have to go through it, but essentially we are able to establish at the level of the population, the distribution of risk factors, showing that this is a population in spite of a relatively low BMI with high levels of blood pressure, on average, high levels of cholesterol, high glucose levels on average. And as you see, we are seeing 2 different time points of how things have changed at the level of the population. We can also measure the prevalence of a disease, like in the case of India. Between Chennai and Delhi, the prevalence of diabetes is about 29% nearly, which is very high. And these are people age 20 and older. If you look at people 50 and older, that prevalence can be as high as 50%, which is a shocking figure. We can also look at the incidence, the rate at which new cases are occurring. And as you see there, the rate of diabetes is about 20.6 per 1,000 person years, which is about 2% per annum, which is very high for any population. And similarly, we can map cardiovascular endpoints, prevalent myocardial infarction, incident myocardial infarction, mortality, etc. So in the interest of time, I won't go through the data other than to show you that this is the value of a cohort. You can describe a population over time. And I also want to point out that this is a huge national strategic resource. As I mentioned, it provides an unprecedented opportunity to unravel novel biomarkers, causal mechanisms for disease, and to inform different phenotypes. All cardiovascular disease is not the same, all diabetes is not the same. And with the advance of omics, with the advance of analytical technologies, we are able to describe these diseases as different phenotypes, each of which may have different diagnostic needs, different prevention needs, different therapeutic needs, different types of prognosis, etc. That is what takes us to precision diagnostics, prevention, and care. Very clearly, this provides us an opportunity to connect basic clinical and population sciences, and the South Asian population provides a unique opportunity to provide a number of interesting disease patterns, disease diagnostics for normal weight people who are yet at high risk of diabetes and cardiovascular disease. And we believe that a cohort like this will inform 2 billion people worldwide. And so just like the Framingham cohort has informed so much of modern medicine, here is a resource which can provide India a leadership role in the science, in the future of science of cardiovascular disease and diabetes. So where we want to go, I mean, this is a cohort we have constructed, a basic cohort, but where we want to go is towards precision cardiovascular disease and diabetes phenotyping and early intervention. The current paradigms are very limited because we tend to look at late disease and look at a few markers and try to predict disease. But what we really need is to granularly, to map the natural history of cardiovascular disease and its phenotypes, diabetes and its phenotypes, and increasingly there is a need to study heart failure. Those are things we want to include. We want to very precisely map these phenotypes along the clinical and subclinical pathways, and then try to and then identify the biomarkers for precision medicine, and also introduce the omics and make the connection with analytics. So like I said, this is the current paradigm. We want to shift it by adding sophisticated measures of subclinical, functional, and structural markers, and then map the entire natural history, connect it to the various risk factors, understand the pathophysiology and risk factors and the prognosis, include to it the various phenotypes and make more careful predictions. And of course, to try and look at the environmental factors, to look at the more careful protein markers and vascular markers, cell-based biomarkers, etc., to study the natural history of the disease, to connect it to the environmental factors and study how environment operates with biology, how the interactions happens, to bring in the omics at different levels to improve prediction and pathophysiology, and essentially to improve our understanding and discovery of the diseases and their phenotypes, to understand their natural history, to understand their prognosis, and to improve diagnosis and treatment, essentially connecting the exposome to the outcome at various levels. So as I mentioned, the cohort offers tremendous innovations as a scientific and informative study population, provides the opportunity for innovations in terms of phenotypes and diagnostics and multi-omic studies, and also provides a huge strategic opportunity for connecting the exposome to multiple time points of omics and to outcomes. We have an extraordinary team, an excellent team science that is conducting the study. And I just want to conclude with some important thoughts. Establishing a well-designed, large population-based longitudinal study offers huge future potential for discovery. It is an essential resource for a country like India. Integrating such studies with laboratory and basic sciences is key. It is important to collect behavioral, social, and economic data in addition to careful omic typings and technology. Discovery is hard to predict, but setting up the vision and infrastructure for it to happen is extremely important. You need good cohort studies, and they need stable resources and infrastructure. And this has been a struggle which we have managed to put together in 10 years. So I will stop there and take questions. Thank you very much.